Chapter 23, Neurocognitive Disorders. So cognition is defined as thinking, and it includes learning, remembering, and using knowledge. There is a lower level cognitive domain that includes attention to the environment and attention to knowledge previously acquired. The higher level cognitive domain includes more complex processes such as abstract thinking, memory, language, and social cognition. The disorders we will discuss in this chapter include delirium, which affects lower level thinking and is reversible, mild neurocognitive disorders, which are a decline in higher level thinking but may not progress to major, and major neurocognitive disorders, which affect higher level thinking, are progressive and they are irreversible. So delirium. Delirium is a confused mental state that occurs suddenly and is always due to an underlying physiological cause. A person has a change in their mental status and they act disoriented and distracted. It is more common in older adults, especially those with dementia and people who need hospitalization. This is a medical emergency and prompt treatment is necessary. Now, these people may experience disorganized thinking, anxiety, agitation, delusions, and hallucinations, with symptoms usually occurring in the evening and night with external orienting stimuli decrease. Now, these patients are a major fall risk because they are going to try to get up without assistance. Page 432 gives you your DSM-5 criteria. Now, epidemiology affects about 10 to 30% of general medical patients, up to 60% in older frail patients, and 20 to 84% in critically ill patients. Now, there are multifactorial physiological causes, which include intoxication or withdrawal from substances, drugs such as lithium, antidepressants, and benzodiazepines, stress, sleep deprivation, and emotional disturbances. Box 23.1 gives you some of your risk factors. Comorbidities include dehydration, electrolyte imbalance, infection, hepatic encephalopathy, metabolic disorders, tumors, and vitamin B12 deficiencies. So nursing diagnosis or assessment. Back it up. Overall assessment. Delirium should be suspected if the patient shows an abrupt change in cognition, such as the inability to carry on a conversation, they stare blankly, and they're not recalling who you are. Now, cognitive and perceptual disturbances. These are illusions and they're misconceptions of reality that often become fears. These can be explained and clarified to the patient. Hallucinations occur when a patient experiences things in the environment that do not exist. They can be visual or tactile. Physical needs. Disorientation is common and can become a danger to the patient, so safety of the environment is priority. Monitor vital signs frequently, and these patients may experience disturbances in the sleep-wake cycle and have hypervigilance, where they constantly assess potential threats in their environments. Always rule out medication as a cause first, especially when your patient is on multiple medications. Moods and behaviors. Delirium can be hypoactive when there is no agitation, or hyperactive when the patient is restless and agitated. Mood can change abruptly and it can go back and forth. Self-assessment, the unpredictability of the patient's mood and behaviors can be frustrating and it can be very tiring for a nurse. There are assessment guidelines on page 434 that you can refer to. Nursing diagnosis, safety is priority. You can see examples of your nursing diagnoses on pages 434 to 435. It is important to realize that these patients have frequent episodes of urinary incontinence, and they need to be toileted every 2 hours to establish a regular pattern of toileting and help the patient learn to trust that the staff places value on their urinary needs. This also helps learn a physical pattern that promotes bladder control. Outcome criteria: patients remain free from injury, maintain fluid and nutrition balance, and comforting patient with calm environment. Planning: ensure the patient has necessary support at home, provide visual cues for the environment, continuity of care providers to minimize confusion and disorientation. Implementation: patients with delirium should not be left alone. Delirium can be corrected if the underlying problem is identified quickly. However, if it persists without treatment, irreversible neuronal damage can occur. Page 535, box 23-2 gives you some interventions you can read over. And as far as evaluation, the patient will remain safe, oriented to time, place, and person, and the underlying cause of the delirium will be treated. Mild and major neurocognitive disorders. So dementia is frequently used to describe neurocognitive disorders with related symptoms and is defined by the American Psychiatric Association as, quote, a significant cognitive decline from the previous level of performance in one or more cognitive domains. So mild disorders do not tend to interfere with ADLs, and they may not worsen. But major disorders do interfere with everyday functioning, and they will worsen. Page 436 gives you your DSM-5 criteria. You're going to want to know this table. Delirium. There is a clouding of consciousness. It is of an acute onset, and it can last 3 days to 2 weeks. Orientation is impaired. Immediate and recent memory is impaired. Visual hallucinations are common. The symptoms will fluctuate and they're often worse at night. Delirium is typically reversible. Awareness is reduced and there will be EEG changes. With dementia, there is loss of memory and intellectual ability. It has an assiduous onset that lasts months to years. Orientation is often impaired. Recent and remote memory are impaired. Hallucinations are less common, and symptoms are stable throughout the day. 15% of cases of dementia are reversible. Awareness is clear, and there are no EEG changes. A woman brings her mother to your clinic, concerned that her 85-year-old mother may have dementia. I'm Ellen, she says when you enter. This is my mother, Veronica. She's not much of a talker these days, so I've come with her to help her express a few things we're both a bit worried about. Ellen continues, well, it's mostly a problem with memory that started maybe 2 years ago. 1.5 maybe. You ask, did something abrupt set this off? No, Ellen says. Mom, do you think some event may have triggered all this? Veronica shakes her head. Does she have abrupt moments of lucidity, you ask? Not really, Ellen shakes her head. She's pretty much the same all the time. Which is an indication that Veronica does not have delirium. D. Her problems with memory have been developing gradually. Remember, delirium is an abrupt onset, but Veronica's problems have been developing gradually over 1 to 2 years. Now we're going to move into major neurocognitive disorders. These include Alzheimer's, frontotemporal lobar degeneration, Lewy body disease, Parkinson's disease with progression, traumatic brain injury, and cerebrovascular disease. So these disorders have various etiologies, with the most frequently occurring major disorder being Alzheimer's. Page 436, table 23.1 give you the common types of dementia. You need to know this table. So Lewy body disease is the second most common type of progressive dementia. It has protein deposits that are called Lewy bodies that develop in nerve cells in the brain regions, and those are the regions that are involved in thinking, memory, and movement. So Alzheimer's disease. It is important to understand the difference in normal forgetfulness and actual memory deficits with dementia. Age-associated memory impairment is experienced by an individual as they get older with the absence of noticeable disruptions in daily life. In dementia, memory loss affects the person's ability to perform ADLs. They may also experience changes in behavior and mood, as well as experience anxiety, depression, hallucinations, and delusions. Now, there are some general symptoms and some definitions here. Aphasia is the loss of the ability to speak and understand speech. Apraxia is the inability to perform skilled movements. And agnosia is the inability to recognize or identify familiar objects, people, or sounds. So let's talk about Alzheimer's disease progressions. In the mild phase, this is the early stage of Alzheimer's, and a person may function independently. They can drive to work, and they're part of social activities. Despite this, the individual may feel like they are having memory lapses, such as forgetting familiar words or the location of everyday objects. Symptoms may not be widely apparent, but family and close friends may notice. Common difficulties include coming up with the right word or name, remembering names when introduced to new people, having difficulty performing tasks in social or work settings, forgetting material that was just read, losing or misplacing a valuable object, experiencing increased trouble with planning and organizing. Now moving into moderate, this is the middle stage, and it is usually the longest stage, and it can last for many years. As the moderate stage progresses, the individual will require greater levels of care. Dementia symptoms become more pronounced, and the individual may confuse words, get frustrated or angry, and act in unexpected ways, such as refusing to bathe. Symptoms include being forgetful of events or personal history, feeling moody or withdrawn, being unable to recall personal information like an address or high school, confusion about what day it is, requiring help choosing the clothes for the season, having trouble controlling their bladder and bowels, experiencing changes in sleep patterns, increased tendency to wander and become lost. They may become suspicious or have repetitive behavior such as hand-wringing. And then we move into severe. This is where dementia symptoms become severe and the individual loses the ability to respond to their environment, carry on conversation, and eventually control their movements. They may still say words or phrases, but communicating becomes difficult. Communicating things like pain becomes difficult. They have significant personality changes that take place, and extensive care is usually needed. They experience changes in physical abilities, including walking, sitting, and eventually swallowing. Table 23.3 on page 437 gives you the stages. Just remember, as the disease progresses, these patients are going to need a consistent schedule and help. Epidemiology. Alzheimer's affects people from all ethnicities and backgrounds, with women being 2/3 more susceptible. Usually occurs in those 65 years and older, with a higher incidence as the age increases. Now, biologically, genetically, there is some indication that genetic mutations increase susceptibility as well as family history. Cardiovascular disease. Brain and heart health are closely related. Other factors include inactivity, high triglycerides and LDL levels, diabetes, and obesity. And then head injury and trauma. Those that suffer repeated head trauma may be at an increased risk. But there are modifiable risk factors. Getting adequate exercise and sleep, socially engaging with others, maintaining a healthy diet, and being mentally stimulated are ways to reduce your risk. Now, in the beginning, the individual may be able to hide their cognitive deterioration, and it is common for family members to experience denial. However, as the disease progresses, the continued deterioration becomes more evident. So for the overall assessment, you're going to look at confabulation. This is a creation of stories in place of missing memories to maintain self-esteem. perseveration, repetition of phrases or gestures long after a stimulus is gone. Agraphia, this is the diminished ability to read or write. Hyperorality is the tendency to put everything in their mouth. Aphasia, apraxia, and agnosia were defined earlier. And then sundowning. This is a tendency for the mood to drop and agitation to rise as the light of day diminishes. They will also have memory impairment. So initially it'll be for recent events, and then as it progresses it'll include remote events. Disturbances in executive functioning. This includes problem solving, planning, organizing, and abstract thinking. And then they will have a diminishment in emotional expression. It is important to determine if the patient is experiencing delirium, dementia, or depression. And you can refer to table 23.4 on page 440 for comparisons. There are diagnostic tests that can be run, such as CT and PET scans, that will reveal brain atrophy. And then a mini mental status exam, which you were given at the beginning of the semester, should also be performed, as well as a complete physical, medical, and psychiatric history and review of symptoms, medications, and nutrition. There is also assessment guidelines on page 440 for you to consider. Now, you do need to do a self-assessment because you need a realistic understanding of the disease, stress management, support and educational resources, realistic outcomes and recognition when these are achieved, and maintaining good self-care. Now, as far as the nursing process continues, the nursing diagnoses, most important is safety due to the patient wandering, falling, and becoming disoriented. Patients can also forget the stove is on or take their medications incorrectly. You can see other examples on page 440, and there is a table on 441 for challenges that families must overcome. Outcomes identification is going to be related to the nursing diagnoses. You can see the table 23.6 for this. Planning support services for caregivers is actually absolutely crucial because they will become exhausted emotionally and mentally. Implementation, we should do a person-centered care approach, help teaching and help promotion, and refer for community supports. An evaluation should occur frequently, especially as the patient's condition deteriorates. The goal is to promote quality of life at the highest level of functioning. Caregiver stress. So daily stresses can accumulate and should be addressed to avoid venting in a maladaptive manner. Stress reduction techniques can include things like meditation, guided imagery, exercise, journaling, and humor. Social interactions can help with feeling supported and provide a healthy outlet. And social support system, or having people available to assist in care, decreases the risk of elder abuse. And we should refer them to community resources and home health care services. So treatment modalities. There are medications for cognitive symptoms. There are 5 medications that have been approved by the FDA, but honestly the benefits begin to subside after about 1 to 2 years of use. You have your cholinesterase inhibitors. Galantamine and rivastigmine are used in mild to moderate stages, while donazepam is used for all stages. It is usually beneficial for up to 1 year and then declines in effectiveness. Side effects include GI disturbance, so they should be taken with food, and know that these patients could develop syncope with these medications. There's the rivastigmine patch, which is approved for all stages. It is indicated for those who have difficulty swallowing medications. And then there's the NMDA receptor agonist. Memantine is approved for moderate to severe Alzheimer's, and it is used after the cholinesterase inhibitors have been tried. Now, table 2310 on 445 give you a list of these medications. There's also medications for behavioral symptoms. These symptoms can include mood swings, psychotic symptoms, wandering, anxiety, agitation, and verbal and physical aggression. These symptoms are the most distressing to the caregiver and usually lead to placement in a long-term care facility. These treatments are used as a last resort because none have been approved, and antipsychotics can be used off-label if they're used with extreme caution. And then there's the integrated therapies. The use of omega-3 fatty acids has been shown some benefit, but it is controversial and it needs further research. So Ellen describes Veronica's problems further. She has trouble remembering things like where she put the electric bill. I helped her find it, and I thought that was that. But then the next week, I picked her up for a lunch date, and she looked really nice. No problem with that. She was all ready to go, but her house was freezing. I said, Mom, did you pay your electric bill? She just stared at me. Ellen continued, but then the next week, I picked her up for a lunch date. It kept going. She blinked at me. I don't know, she said. Well, okay, I said, let's see, where's your checkbook? I don't know, she said. Just stop asking questions. I thought she was going to cry. Veronica tries to refer to the electric bill, but ends up saying, you know, the invitation, what is this a sign of? A, aphasia. It is the loss of language ability.